शुरू नहीं हुआ है ना, 3 नहीं बजे हैं। वैसे ही देखो ज़्यादा अच्छा रहेगा।
Yes. YouTube is linked now.
Yeah, YouTube is live. I can see.
Now it is live.
Yes.
Yes, sir.
YouTube is linked, man.
Good afternoon, sir.
Thank you. Your voice is not clear, Vishwanath sir.
Ah,
Okay. Uh,
good afternoon, today, sir.
Yeah, within a minute or two, we should start.
okay.
एक मिनट।
ઈશ્વરભાઈ હું તમને કોલ કરીશ પછી ચાલશે ને? ઓકે ઓકે હા.
Yeah, that is good. So,
So should we start now? It's
yeah, I think we should start.
Yeah.
By this time, okay. Yeah, go ahead.
Okay, a very good afternoon, sir, and very good afternoon to all the participants and delegate members who have joined in for this Mission Spine course, which we are conducting on every Wednesday and Saturday. I welcome you all on behalf of Alembic Pharmaceuticals for the Mission Spine course. And today, as we already know that we are having a series on transforaminal lumbar stenosis, surgery, stitchless, and under local. Today, we are going to have our 7th webinar, and the topic which the eminent faculties from Mission Spine Foundation, that is Dr. Satish Chandra Gori sir and Dr. Bhupesh sir and Shiraz sir, would talk and cover all the aspects on lower zone surgery. So without further ado, I take this opportunity to welcome all the eminent panelists and speakers, and I would like to hand over this session to Satish Chandra Gori sir. Sir, I welcome you and I hand over this session to you.
Okay, thank you. So today what we are doing is this is our 7th in a series of 8 webinars where we have tried to introduce our new concepts to all of you. And these concepts are basically to highlight the point that we can treat lumbar canal stenosis by transforaminal endoscopic surgery. Now, for many of us who have come from the traditional surgery background, it may be very difficult to appreciate the point which we are trying to make, mainly because there are certain concepts and certain jargon which has been put into our head with our training, and for years together, we have been highlighting that aspect. We have been highlighting those concepts. Those concepts are mainly like this. Number one, surgery for lumbar stenosis is done under general anesthesia. It is done through the interlaminar route. It is done by removal of ligamentum flavum, which lies in the interlaminar window from pedicle to pedicle and from edge of lamina to edge of lamina. And that's it. The posterior wall of the lumbar canal is the one which is causative of most of the symptoms in lumbar canal stenosis. Once there was an introduction of some form of endoscopic surgery or minimally invasive surgery, there was a little shift in some people's actions where they started going little to the side and started undercutting the facet, etc., and claiming that they are minimally invasive and saying that they go over the top or whatever. But still, the basic philosophy of treatment remained the same. The descriptions which we look at in the traditional surgery are mainly done with posterior midline axis in mind. So the labeling, the nomenclature, the jargon, etc., has all been with that single point in mind, that all surgeries are under interlaminar axis, etc. Now, there are a lot of changes in the concepts which are related to the causes which give symptoms in lumbar canal stenosis. And now that we have matured enough to do transforaminal surgery for the disc herniation, where we have extended our axis when we are doing up migrated or down migrated herniations to the canal, to the epidural space, we have now come to a stage where we can go in for working on the roof. So there are several concepts which are new and which have to be taken into account if you want to shift to transforaminal access. The first thing which you must remember is our surgery is under local anesthesia, where the patient is fully awake and aware throughout the surgery. As all of you are aware, keeping the patient awake or under local anesthesia is very important to make it safe and to make it precise, especially when we are doing surgery in case of disc herniation, where it is for pain. Keeping the patient awake and aware when you're operating for pain makes a huge difference, because you can easily correlate the symptoms and the images and the pathology when you are looking at it. It may not make much difference for targeting in case of lumbar canal stenosis, because the surgery in stenosis is still image guided. But it makes a huge difference in stenosis, because most of the patients in stenosis are elderly people and they have medical comorbidities in the form of diabetes, cardiac problems, asthma, many other issues like obesity, etc., etc. So with all these things considered, we need to remember that our surgery under local anesthesia makes a difference. The second thing is, since we are going through the foramen, we have relabeled the zones which in the traditional surgery and nomenclature were more with respect to the nerve root path. So in case of traditional surgery, we used to call it as entry zone, where, for example, for the L5 root, the entry zone was in the lower level or lower zone of L4-5, the mid zone, which was around the medial and inferior border of the pedicle of L5, and the exit zone, which was the foramen of L5-S1. Whereas for us, the upper zone, that is the zone between lower border of pedicle and the lower border of the vertebral body, is the upper zone. The middle zone is the disc zone, and the lower zone is the one which is below the lower end plate at the disc level. For example, at L5-S1, the lower zone is below the upper end plate of S1 or below the disc of L5-S1. Now, what is the importance of lower zone? In traditional surgery, as I mentioned, most of the people have been talking about accessing the posterior wall of the canal and remove various portions. In between, I did a literature review of lumbar canal stenosis and traditional surgery, and there are more than 34 variations of traditional surgery where various portions of lamina or interlaminar area, ligamentum flavum, facet, etc. are removed. What we must remember is that when we are going in the lower zone, which also is called as the lateral recess, we have to look after the tissue changes which may be occurring at the lower pole of the facet joint. Now, the main question which a traditional surgeon naturally would ask, can you really reach that area and decompress the nerve as it is turning from being a traversing nerve and going out of the foramen? For example, in lower zone of L4-5, the L5 nerve, which is the traversing nerve at L4-5, is going in the lower zone, entering the lower zone, and going out below the pedicle of L5, out of the foramen at L5-S1. So my colleagues, Dr. Shiraz and Dr. Bhupesh, are going to present these concepts on lower zone surgery and try and convince you that we can do the same surgery under local anesthesia. Now, what are the differences? What are the ticks? What are the tricks? And what are the tips about it? They would be able to guide us and enlighten us. Now, Shiraz, if you are ready, please set up your presentation. Shiraz?
Hello.
Yeah, if you're ready, please start your presentation and just let me know if Bhupesh is there or he's yet to come.
Yes, I am here, sir.
Yeah, okay.
Sir, Bhupesh will present his part first, and then I will.
Okay, so you please go ahead and let us start with the presentation. If you're
Okay.
going to need some time, let me know. Otherwise,
So yes,
who is going to talk first?
give me a few minutes. I am just searching my presentation and just making.
Yeah, okay, go ahead. So I'll just take one moment or 1 minute before you start. So the lower zone at L4-5 is the zone below the end plate, upper end plate of L5. It starts from there and it is right up to mid part of the pedicle of L5, and it can be extended up to lower border of the pedicle of L5 as the extended lower zone. Extended lower zone, we are not much interested because it is all bony. Vertebral body of L5, pedicle of L5, lamina of L5 behind. And on the medial side of that zone, if we are talking of half the division of the canal, then it is the dural sac. Now, in the real lower zone where we are considered, we have to talk about the body in front, the pedicle on the side, and at the back, it is the lower pole of the facet joint. Now, I think Bhupesh, you are getting ready, so please go ahead and
Yeah.
start your presentation.
Hello. Good afternoon, everyone. Today I'm sorry, sir. Last time I missed the presentation about mid-zone stenosis. So today
Yeah.
I'm combining both because it's stenosis almost lower mid-zone and lower zone almost are together. So I'm today presenting both mid-zone and lower zone stenosis, how it occurs, and mainly we are concerned about here about the transforaminal anatomy of mid-zone and lower zone, and we have compared also with the traditional midline anatomy. So what we are doing different here on traditional surgery, and what we have invented something for the transphenomenal surgery and stenosis.
Okay.
So the structure, which are the structure responsible for the mid-zone stenosis? Mainly the lumbar disc herniation. It's the most common cause of mid-zone stenosis, and it's sequelae. Chronic disc herniation and calcification and subsequent osteophyte formation and all these things. Second is chronic disc collapse and disc calcification, mainly the structural failure, what we call chronic disc collapse, which gradually causing the hypertrophy of ligamentum flavum because of to stabilize that segment. And hypertrophy of ligamentum flavum will invariably cause the lateral stenosis and root entrapment. So third is end plate osteophyte. upper end plate and lower plate. If the osteophyte is on posterolateral location mainly, they are contribute to the stenosis. And then like obviously the ligamentum flavum which are staying in the lateral recess, mainly the lower zone stenosis which are responsible. Facet osteophyte and facet cyst. This is the most common cause. This is a very not most common. This is a very common cause for the stenosis in the lateral recess, especially upper and lower, middle zone and lower zone. Third is two roots in the stem foramen. Many times they can cause, they can present with the symptom at stenosis, because here minor amount of stenosis or hypertrophy of flavum or disc herniation will give rise to symptoms. Basically, mid-zone stenosis in transforaminal anatomy, it's a retrodiscal area of Lee's entrance zone. We have divided Lee's entrance zone, mid-zone and exit zone. So here it's a retrodiscal area. We call this entrance zone. Second is lower zone stenosis. Here, mainly the main important structure which causing the lower zone stenosis is the hypertrophy of inferior articular process and junctional, especially in the junctional area of superior articular process and inferior lamina, where we can see, yeah, everybody is visible. Here is a superior articular process. Here is a inferior lamina of lower vertebra. So main positive stenosis for lower zone is this area, junction between this, and here is inferior articular process. So when we are standing or upright posture, walking, this inferior is impinge on the traversing nerve root. So that will give rise to the stenosis. And obviously inferior end plate osteophyte also sometimes contribute and root abnormality. Here we call is Lee's mid-zone parapedicular area. And Lee's exit zone is like what we have seen, lower zone exiting route. Like what it for transforaminal anatomy is the upper zone stenosis for Lee's exiting area. So here we can see the anatomy. This is very nice figure. I like this figure very much. Dr. Gore has presented this in forum. Here is upper zone, if it called mid zone with discal area in lower zone. So it's a lower zone stenosis mainly due to ligamentum flavum hypertrophy and hypertrophy in the SAP and superior laminal junction area and impingement of an inferior articular process. Here again we can see in the sample. Here is this if osteophyte is here and stenosis here, it's responsible for the mid-zone stenosis. Ligamentum flavum can cause mid-zone and lower zone stenosis both. And here hypertrophy of facet capsule or facet cyst can cause mid-zone stenosis. And again, here if you see this part particularly, this part inferior articular process, here is inferior articular process, and here is superior articular process. So this area is especially responsible for the lower zone stenosis. And now a little bit of about this degenerative disc disease. Most of the herniation resolves spontaneously with conservative treatment. According to the most of the study, 80% herniation resolve with the conservative management. Conservative management in form of bed rest, in form of local non-steroidal anti-inflammatory drug and pregabalin and gabapentin molecules. Sometimes we need to add the steroid, especially to reduce the inflammation. So small group of the patient need intervention either in forms of root blocks, we call it selective nerve root block, or intradiscal block, or some form of surgical intervention like endoscopic intervention or microdiscectomy. The herniation is the more larger herniation, spontaneous regression is most likely because it move to the epidural space where the phagocyte and blood is going on. So epidural blood is, when it comes into contact with the epidural blood, the phagocytic process is going on, so that herniation resolves more likely. Smaller the herniation, especially which is entrapped into the annulus, they are less likely to regress because they have contact with the parent disc. So here patient have more symptom and they are liquoring patient coming to us for frequently for this kind of symptoms. Most of the annular tear, something about annular tear. This is the most of the annular tear, they are healed by fibroblastic proliferation. If it is failed, most commonly due to the trapped fragment inside the annular tear, and it converts into the chronic annular tear, or what we call it annular ulcer. And you have what are the content of the annular ulcer? Because it contains the granulation tissue with inflammatory cell and vascular ingrowth. What we call it chemical radiculopathy and neovascularization. The symptoms of the vascular ingrowth and chronic inflammation is chemical radiculopathy. Sometimes we cannot find the big disc, but patients still have a radiculopathy because of this chemical process, neovascularization. This is the pathogenesis. once discal tissue is herniated, it comes in contact with the epidural space where the immune system are there, which cause phagocytosis and neovascularization. How it occurs with the macrophage, which release the TNF alpha and interleukin. What we ultimately it stimulates the proteinases and which cause disc degradation. Most of it leads to chronic disc collapse and chronic disc or degenerative disc disease. And if it releases the prostaglandin, then nerve root injury or sometimes pain and radiculopathy is due to the prostaglandin release. Now come to the lower zone. What are the mechanism mainly? So some due to the disc herniation on some micro instability of the facet joint or lumbar motion segment give rise to the chain of the event, which nature try to stabilize with its own. What it called, how it try to stabilize it, causing the hypertrophy of ligamentum flavum or hypertrophy of inferior articular process, or actually not a hypertrophy but osteophyte formation in the inferior articular process and superior junction of inferior and superior articular process. And the third is reduction of the disc height. All this structure contribute to the impingement of the junctional area of superior articular process and inferior lamina on standing and walking. So most of the patient of lumbar canal stenosis, we have found patient doesn't have a symptom on the supine or lying down position. Here, when the impingement occurs, there's a reduction of lateral recess zone in cross-sectional area. We can see the cross-sectional, there's a reduction of significant reduction, which lead to reduction in the movement of the traversing nerve root, which in turn lead to the vascular congestion of that area. Vascular congestion is main causating factor for the lower canal or mid-zone lumbar canal stenosis. Here is the vascular phenomena, how it occurs. I think most of us, we are familiar to this figure. Subarachnoid mechanical force leading to subarachnoid space occlusion, then circulatory disturbance, injury to the nerve root, then breakdown of blood nerve barrier, then intraradicular edema, increased endothelial pressures, conduction defect, and what in turn lead to deep muscular pain and typical claudication symptom of a neurogenic intermittent claudication. And now we come to the management part, where we are concerning about the transforaminal access, how we manage the mid zone and lower zone stenosis via transforaminal route. So these are the common surgical steps we follow. First, we access it transforaminally. We remove if disc is causative factor along with posterior calcification or hardening of the posterior longitudinal ligament. We excise the disc and we cut the posterior longitudinal ligament and try to decompress the traversing nerve root. The third thing, if we are not able, if there is too much hypertrophy of ligamentum flavum, mainly due to lateral recess stenosis, we need to add the foraminoplasty. Here we remove the non-articular part of superior articular process adjoining upper part of the pedicle, what we call the superior oblique pediculotomy, in order to remove the entire flavum from mid zone to lower zone. And third is with Carrison punch and upbiting, grasper and curate, we do the flavectomy. And fifth is osteophyte resection. If osteophyte is there in posterolateral area in upper and lower end plate, we remove with the articulating burr, or we can remove with the curate and trephine. And last but not least is disc height restoration. If there's a chronic disc collapse, we mainly due to the stenosis is mainly due to disc height collapse. Then we have to search for the option for how we can restore the disc height. It's like Dr. Gore has already started very back, I think 10 to 12 years back with the between cage. It is not available in market, but now we are, I think we are about to get that cage. We can restore the disc height without stabilizing, or we can add stabilization if it is instability due to the facet joint arthropathy. So here, this is the case, a 64-year-old male with left leg claudication. Here, patient is not able to walk more than 100 feet for less than, he can able to stand less than 5 minutes. So here you can see there's significant disc herniation with lateral recess stenosis, and you can see the lower part, there is also lateral recess stenosis with a disc herniation. So it's combined mid zone and lower zone stenosis. So how we do with transforaminal access? So what are the point here? What are the structure we need to address? We need to address this disc, and in transforaminal many times if we remove the flavum unilaterally and we just decompress the one side, then whole things moved on next side, and we can automatically opposite side of nerve root can decompress. Here the patient is main symptom is left leg pain, so we address this thing. We should address this thing on the left side. Okay. 1 minute. No, it is something different. You mean? Sorry. Wait, this image is not working completely. Yeah, you can see we did here the foraminoplasty. We remove the herniation, this herniation part completely. We have not gone completely opposite, but because we have to just maintain the stability, we have removed the PLL whatever needed, but we completely decompressed the opposite side. You can see, and also we have decompressed the lateral recess. Here the phlegm which was there in the lateral recess, we also removed. So this is a traversing route. We did complete decompression till lower end. So we followed with post-op MRI. Here you can see the foraminoplasty. This is a complete decompression of traversing route. And here we need not to remove the entire phlegm, because the phlegm which is causing the stenosis of the lateral recess or traversing route, we need to address that. And we also remove the disc till midline. Here you can see the little bit of PLL is there, but we remove the entire disc herniated part below the PLL. So just to maintain the stability, you can see the MRI. It's nicely decompression. Again, here the 46-year-old male with severe left leg pain since 2 years, symptom increase since last 3 months, L5 dermatomal involvement, no neurodeficit, walking distance is less than 500 steps. You can see is again mid-zone stenosis with lower lateral recess stenosis. Same we followed what we did in last patient. Here the axial sagittal image of the same patient. We removed with this trapped wrist fragment via transforaminal route, and we did the foraminoplasty and removed the same fragment. This is the before foraminoplasty. We have addressed this area. This one. We remove this phlegm. We completely decompress the traversing nerve root. So it is a dural dissector. We are confirming that anything is not, there is nothing left below to remove the fragment. We are asking patient to cough, just to ensure we are not. This is a disc fragment we removed. Sorry, I have not. The post-op MRI is done, but it's not available here. This is a third case. Here, 62-year-old male with severe right leg pain since 3 months, unable to stand more than 30 seconds, can't walk more than 10 steps. So here you can see the MRI of the same patient. Again, the lateral recess stenosis with mid-zone stenosis, right side disc herniation, down migrated, little bit of down migrated fragment. Here we combine foraminoplasty, what we call the oblique pediculotomy. We call it superior oblique pediculotomy. I am showing this.
Bhupesh, I suggest that you again.
That video is not running, but I am showing in another folder. After this, we did the transiliac foraminoplasty with burr and reamers. You can see our movement of the hook.
Bhupesh.
We reach till lower zone. We decompress it nicely. Here is part of the foraminoplasty bone fragment and disc.
Hello.
Yes, hello.
You can see it's completely floating, traversing.
Hello.
I think we are not
foraminoplasty oblique pediculotomy zone. You can see they have removed nicely.
Okay.
Now there is a junction of SAP and IAP.
Hello, Bhupesh. Hello.
This is a complete movement of the traversing nerve root. We have decompressed nicely and patient
Bhupesh.
on table on.
Hello.
Hello.
Yes.
This is all we have done. And like one more that how we do the superior oblique pediculotomy. I'll just show you that image.
Hello, Bhupesh sir. Hello. Sir, are you audible?
Hello. Hello.
Sir,
Bhupesh, am I audible? I think he's unable to hear me because he has made
Yes,
his
that was
sound
the
zero.
reason sir is not able to hear me as well.
Shiraz, am I audible?
So I'm not getting the voice.
You
I
increase
think
your
sir,
voice.
we are not. Sir is not getting our voice. Sir just said that he's not getting our voice.
No, Bhupesh, what I'm saying is you increase your...
Sir, you and both Bhupesh both are very much audible to all of us.
No, I'm not audible to Bhupesh. That's the problem.
Yeah, sir. It means he has decreased his the other
Yeah,
volume.
but then we have to tell him.
Yeah.
He's not even looking at my hand when I'm waving my hand furiously.
Let me call him, sir. Let me call him.
Yeah, we are calling.
Yeah, this is all. आपण फोन હા સાહેબ હલો હા શું થાય છે યાર હલો
Hello.
હા શું થાય છે સાહેબ અવાજ નહીં આવતો હરકો okay
Yeah, okay, Bhupesh.
Yes, sir. I'm getting your voice. Sorry.
I wanted you to give a better pre-operative image analysis of this patient before
Okay.
you showed the oblique pediculectomy, because here in this patient, on the right side, we have a down migrated piece of disc which
Okay.
has gone in the lateral recess. So
Okay.
please explain those images in more detail.
Okay.
And I have two comments to make. Comment
Okay.
number one, these images, especially the cross section up there, the
Yeah.
third from the left, that is what needs more
Yeah.
explanation. That piece which has come down,
This one.
the one
Yeah.
behind the body, exactly that
Yeah.
one. And there are two comments. Comment number one, we should stop using the word foraminoplasty, because we are not doing foraminoplasty, we are doing a canal plasty or a channel plasty, as we decided to call it.
Okay.
Foraminoplasty, yes, we are doing, but there we don't stop, we go ahead of that. And
Okay.
second point, which is very important, is this area of lateral recess is the area little below that. I mean, if you see the fourth image,
Okay.
somewhere there is the artery which is coming in. The
Yeah.
segmental artery is coming in just below the pedicle and
Okay.
supplying the radicular arteries. So it is
Okay.
very important to decompress this area to improve the arterial circulation and to relieve the venous congestion. So these
Okay.
points are very important. Now you please explain those images right from the first image on the left to the fourth image on the right,
Yeah.
so that we know. There's
Okay.
one more point. The point is, in case of posterior midline surgery, we never pay attention to the anterior changes. I
Yeah.
mean, in pure stenosis. So we
Okay.
need to be very careful here, where we are talking about the end plate changes, the osteophytes, the loss of concavity of the posterior annulus, the changes around the PLL, etc. So please go ahead.
Yeah. Yeah, here you can see there's a lateral, this is the disc for L5 end plate, this is L5 S1 disc, this is the S1 end plate, superior end plate, and the S1 body of the S1. Here we can see the stenotic stage starts from here, it's just above the end plate here. You can see here, the disc herniation is there along with a little bit of phlegm hypertrophy. This is exactly the disc area L5 S1. We can see that both disc and ligamentum phlegm, both are hypertrophied, especially in the lateral recess. and more lateral. If we go more laterally, then also there is a part of hypertrophy of supraarticular process. Tip of the supraarticular process also is hypertrophy. So here we need to decompress all these three areas: upper zone, mid zone, and lower zone. So upper zone we have very well documented in transforaminal anatomy. We cannot, the interlaminar endoscopy cannot do upper zone decompression, especially because it's very difficult to reach by interlaminar. So here the transforaminal surgery is very effective. Now for mid-zone stenosis, we can debulk the disc, we can remove the PLL, or we can remove the structure below PLL, and we can decompress this very well. Here you can see the ligamentum flavum on both sides is hypertrophic. And on subsequent images here, especially, you can see the lower zone. Especially here, there is a disc. It must be, the disc is not, when I did the surgery, disc was not that soft. It was a little bit hard and calcified disc. And so we need to use the curate and burr. So when you can remove this part of oblique pedicle, you can remove this part, you can directly access this, especially when we can see in the images. This part we need to address to decompress the lower lateral recess, lower zone. Here in the last, you can see here in the video, I have turned upside down. These are phlegm, little bit of phlegm. I have removed almost more than 30% part of supraarticular process. This is the IAP coming up, and this is a junction of IAP and SAP. And we burr the part of the pedicle also. So we can completely decompress the lateral recess. Part of the disc was here. We completely remove the dead disc, and we completely decompress the traversing nerve root in the down. Hello?
Yeah.
Sir, any comment now further?
Yeah, one comment again. When you have shown this cross section, no, go back. Yeah. The third image from the left in the upper row, you have to emphasize the point that this area has a bone all around except on the medial aspect. It has the vertebral body, it has the pedicle, and it has the facet joint. Now, in this facet joint, we have to remember that we always have the superior articular process, which is ventral to the inferior articular process.
Yeah.
So doing a medial facetectomy in the traditional sense only deroofs this part.
Yeah.
It is not necessary. I mean, it doesn't have anything to do with the nerve root there. But it is a tradition that we have been removing the medial part of the facet because that's the only way you can deroof that part. And in our surgery, how our surgery differs, you please explain there.
Yeah, here what in transforaminal surgery for lower zone stenosis, instead of removing the medial, instead of doing medial facetectomy and instead of cutting the edge of the junction of the superior articular process and inferior lamina, what we do, we remove the part of the pedicle, oblique pediculotomy, and we remove the part of the inferior articular osteophyte, which is there in the inferior end plate. So we here we do ventral decompression. In the traditional interlaminar surgery, we do dorsal decompression and we decompress the traversing nerve root. Instead of that, here we are doing the ventral decompression. So the traversing root is in between this structure. Here the dorsal structure is the ventral structure. Disc, inferior end plate, and the flavum in the lateral recess. Flavum is here. So what we remove the flavum, inferior osteophyte, which is there in inferior end plate, and we remove the disc. So in order, it is the same, we decompress the traversing nerve root from the ventral side. So we have to improve the circulation of the lateral recess. We have to improve the movement of the traversing nerve root in order to relieve the symptom of the lumbar canal stenosis. So we did not to remove the medial facet of medial facetectomy or inferior articular process. Here, instead of that, we are doing this surgery from the ventral side. Sir, anything needed to add in this thing? Hello?
Yeah, no, nothing, not really.
Okay.
What you have done is very good. You have explained it very well. And there's one more small addition is that we have seen this coronal oblique view for the ligamentum flavum, where it tells us that it goes from the midline up towards the upper pedicle. So it is more involving in the upper zone and where it crosses the facet joint towards the pedicle. So in the middle zone also. In the lower zone, in general, the ligamentum flavum is not extending beyond the mid-pedicle line. it is covering the undersurface of the facet joint for sure. So what you have done is excellent. I would say that if you are able to explain these images, the ones which you have already explained, and your surgical access and the structures which you see in the surgical videos, it is very good. It should convince anybody who is unable to otherwise appreciate what we do. So very well done. Go ahead.
I think that's it from my side. I think now I'll hand over to Dr. Siraj Munshi for the next presentation. If yes.
Hello. Yeah, Bhupesh.
Yeah. Should I stop sharing the screen?
Yeah. Okay, let me share my screen.
Yeah, by the time you set up, I think if we have, are you going to start immediately or should we have any questions?
Yes, sir, I can start immediately.
Okay, please start. In the meantime, I'm sending one paper on the chat window where I will send a paper about 3D fusion imaging of ligamentum flavum, which will clarify what we have been talking all the time. And I have also put in 2 books and 1 paper on the chat window. So all those uh, who are on laptop or desktop, they can immediately download and see. Shiraz, once you're ready, you can go ahead.
Okay, sir. I'm ready, and am
Yeah,
I
please.
audible, sir? Yeah.
Yeah.
Okay. So, sir, most of the part is covered by Bhupesh, and since he was absent, so like he has to take the lead today. So I'm just complementing to his topic. So again, mainly the lower zone surgery is so this traversing root pathology is mainly maybe because of the down migrated disc herniation, or maybe the facet capsule. It may be due to the base of the superior articular process, or facet capsule can be the reason, or hypertrophied ligamentum flavum. It's not the
Shiraz, we are
facet.
not able to see the video. Are you sharing the screen?
Yeah.
I'm not able to see.
Yeah.
Okay. Okay. Let me reconnect it because.
Yeah. I mean, I can hear you and see you on the video, but share screen is not.
Now.
Yeah, now, yes.
Now it's okay.
Yeah, now I can see. Yes, very good.
Okay. So this basically the lower zone surgery is mainly for traversing root pathology, and this traversing root pathology, compression of this traversing root can be due to either the disc or the facet capsule, or base of the superior articular process, or hypertrophied facet or ligamentum flavum. So actually we need to approach little more oblique here, and then only we can go and we can work, and we can do. So like in some of the cases, like Rupesh showed you how to do the pediculectomy, and how you can go further. So I'm just going to narrate about the new instrument which can be very useful. So these are the 45-degree angle annulus cutter, and the different kind of grasper, which opens on the upper side. So this actually very helpful to work on the roof. And to do the bony work, we do have the trifine, we do have uh, uh, the special instrument called the rasp. So rasp is more like blunt on the tip, and you can use as a manual, like the manual bone drill, and you can drill the part of the facet base of the superior articular process, or the pedicle. So this is like one of the video which is showing that how we use the manual bone drill. So like in this video you can see that this is actually the video of the transilia, but you see whenever we do the transilia, the same time we can we can work on the facet. And usually we do this mainly for the alpha S1, where sometimes the patient is having the very collapsed disc, and you just need to make the foramen wider, And once you make the foramen wider, you can pass your instrument, and you can pass the cannula, you can pass the dilator, and then you can put the scope. So you will have the better access to the structure medial to the facet. So actually, we do the serial gradual dilatation, and we do it with first with the small size 4 millimeter uh, gradual bone drill, and then we go with little more, and then we go it. So you can see it here. So normally we do the dilatation up to 9 millimeter. So actually this will definitely accommodate any size of the transforaminal endoscope, because the highest cannula diameter is 8 millimeter. So you have some access that you can gradually go further. So this is a long video. So I just want to show that this is the way we work on the bone, and this is one of the very safe way. So like now you see I'm putting a little more bigger bone dilator.
Now, Shiraz, I think there is a comment which is due.
Yes.
Hello.
Yeah, I can hear you, sir.
Yeah, the comment is the foramen is bigger in the upper part, and in the lower part it is rectangular and smaller. So if we are able to increase the size by undercutting the facet, then we are able to access the inner contents of the canal better. So what you are
Yes.
doing is very systematic and very principled, enlarging the foramen and access window for us to go in.
Yes. So like sir, when there is something below the level of the inferior end plate, then you have to go a bit oblique, and then only you can access those structure. Especially when we are working with the ligamentum flavum and very high down migrated disc. So usually the only disc pathology we can easily treat with transforaminal approach, and you can go inside the disc and you can work. But when you are suspecting that the migration is very down, then in that case you have to do the bone work. So I'm going to come on this point again. So I'm just showing this video that how this is being done. And since this is like we always say, this is done on the local anesthesia. So like with local anesthesia, it's easy. So now once you are sure that your dilatation is enough, then you put the dilator, and then over the dilator you put the cannula, and then you put the scope. So this was just to show the how we can do the bone work.
Yeah, there's one more comment, and the comment is the upper part of the foramen has the nerve. The lower part of the foramen is free of any neural tissue. So you
Yes,
can easily do the bone work very safely
very
without
safely.
injuring anything. The only
Yes,
issue is in the mid part of the foramen. When you burr or when you undercut the facet, you land in the disc. In the
yes,
lower part, you will land in the body or in the upper end plate, which can be very messy. So you
yes,
need to be a little more careful and not
yes.
exceed the medial travel of your burr.
Yeah. So like very simple. We should always keep your CM in the AP view, and you always keep on looking at the CM where your instrument tip should not cross the medial pedicular line. That is your safety point. So these are the couple of method. I'm just showing the how the bone work can be done, and this is like in previous lecture also I put this video. So this is also the bendable burr. So you can see that this is a straight burr, but once you go through the scope, you can just change the angle. So this way you can come in the line with the endoscopes. So like most of our endoscope are 25 to 30 degree for the transforaminal surgery. So now with this, you can just put it inside, and then under the vision, you can do the bone work. And this is like very precise. And since we use the diamond tip, so usually with the diamond tip, so now you see so this is like it's very important to have the tactile feeling also here. So like then gradually you go up, and then you can drill the facet more and more. So this way with the use of diamond tip, the chance of the bleeding is very less, because diamond will convert all this bone into the dust, and it will automatically seal the any bony oozing. So and like this is also one of the way of like how we approach. So sometimes you have to go quite oblique also. So I'm just going to show you one of the patient. So like you see, this is more like a suprapedicular approach, a suprailiac approach for alpha S1. But you see that the iliac crest is very high, and this is how we can go more in. So again, like we are going very oblique, and then you can see in the lateral view also, and you have to do a good manipulation to get the access, and then you can go inside. So like you see in this video, I'm just want to show the trajectory, that how oblique is the entry for this particular patient. So usually what we do, we still go at the lower end plate, and then you gradually do some of the work on the annulus, because here we it's very important to work on the roof as well as on the floor. So the floor is annulus, so we have to remove the hard annulus, and then gradually you can keep on coming out, and once you come out, you can do the you can keep on doing the bony work. So it's always safer that if you have your cannula which is fixed, and once you go inside, then gradually coming out like this will help you to control your instrument, and then gradually you find out the facet, and then you can start drilling the facet with any of the instrument you have available.
This is the area.
So like here also you can see also, and you can also
Right now it is
confirm on the
going between
X-ray
the
that
teeth.
now you are on the facet. So this is like you can see that this is a hard annulus we are just removing. So this is one of the case. It's not done by me. It's done by one of our colleague, Dr. Janmay Jai, and this is he just did it. I think last week, and this is excellent way to confirm that even we can remove the ligamentum flavum very nicely, close to the facet line also. So you can see this is a pre-op MRI. So you can see that there is a very tight stenosis, and it was the patient symptom was on the one side. So you can see the L4-5 is very tight, and so now this was the intraoperative picture. So even how much dorsal you are there, you
As you
can
can
always
see,
confirm on the
hook
the
is going
X-ray.
behind the
So you can
dorsal
always take the lateral view,
ventricular
and in the lateral view,
dorsal.
when you
If
put the
you
hook,
will see
the
closely,
hook should looks into the canal,
shoot the
which is
should show you where apex
posterior
cord.
to the
It's
posterior
now
vertebral body
set
line.
against the lamina
So here you
so
can
that
see
it
that
won't
once
rotate.
he's
It also
inside, and he's
generally looks
probing the
young.
structure. So uh, so in the AP view, you can see that this is he's
Shoot.
behind the pedicle, and at the same time, if you take the lateral view, so you can see that this
Shoot.
down approach is also possible, and you can definitely access it
All
once you are very
criteria is
clear
clear.
about the anatomy and the
Dorsal
understanding of
ligament.
the three-dimensional anatomy of
Okay.
X-rays, as well
Okay,
as
fine.
video picture coming from the scope. So this is again
So as you can see,
one more
my
picture, one more video
hook
we will
is
be
going
showing.
behind the
So like with the hook is
ventricular
one of the very important
dorsal.
instrument,
If you give
and
the
I
space
use
over
it
here,
use it
let me take
extensively
a
even to
shoot
detach
just
the
to
ligamentum
show you
flavum
where
also,
apex
because
cord.
this the tip
It's
of
now
the hook is atraumatic,
set against the
and at the
lamina
same
so
time
that
you
it
can
won't
palpate. So
replicate.
like it's your
It
finger
also
which is inside the
generally looks
scope,
young
and you can
over
just
here.
feel all the structure with the tip of the hook, and then you can confirm it. So here if we take the lateral view, then you will definitely identify the tip of the hook is inside
Shoot.
the canal, and that way we can always confirm. So here again, it's very important to have this
So all
patient under
that
local
area is
anesthesia,
clear.
because here
Dorsal
you
ligament.
are inside the canal, and if you have any problem to the patient, the patient can immediately report to us. And now this is the post-op MRI. So you can see there is a nice decompression on L4-5, and this is the best picture you can see. So so you can see this is very clear that the part of the ligamentum flavum which was there
Please
before.
show it by your cursor. Just point out the area. We can
Okay,
see,
sir.
but just point it out again for the benefit of those who are unable to appreciate.
Okay, sir. I can just I'm using
Yeah.
my
Okay.
phone.
Okay. Yeah, we
This
can see the pre-op.
yes. And now you see
No,
this
this is
this
the post-op. Yeah, I can see the white area which you
yes
see on the left side is the one which has been removed. And
removed.
all doubts about our ability to remove the ligamentum flavum are absolutely over. Very good.
And sir, you can even more appreciate that the structure which is more medial to the facet,
Yes.
we can definitely remove it.
Yeah.
So
I
here
will make one comment here. The comment is like this, that we have unnecessarily been burdened by our traditional talk about central canal stenosis. Now, the problem is in case of stenosis, the subarticular area which you just showed is much more important than what is traditionally called as central stenosis. There is nothing like central stenosis. I mean, the idea which most of the people get the moment you utter the word central is as if it is posterior midline central. It is not so. It is always subarticular area, which you have just shown beautifully. And if at all you talk of central area, that is the area which is below the PLL. Bhupesh already showed that you can very clearly decompress everything which is lying below the PLL. One small comment on Bhupesh, what you said about PLL, is that we normally don't remove the PLL because PLL is very vascular. You go right up to the edge of PLL and you work under the PLL, and the PLL is left intact. I mean, the PLL is not removed. So the PLL will remain. So very good demonstration. Now,
okay, sir.
please go ahead.
I just want to give you a couple of the inputs. Sir, here when we are working, so like the phlegm is here when the phlegm is hypertrophied, and when we use the hook, so it's very easy for us because the hook is a blunt instrument, and you can go and you can just the pull the phlegm inside. So like the flavor will come into the kind of pieces, and it's like it's not difficult to remove the phlegm here because we have the bendable instrument like hook and curate. So with the curate we can do a kind of a heavy work, but the hook is one of the very important tool here because you can under vision you can show you can see you can go more medially and then you can pull it back. So this works like a backbiter. So it will pull the structure or the things what you want to hold inside. So and that way then you can use the special grasper which is having the upbiting, and it's very comfortably you can remove the phlegm which is more medial, and especially when you do it under local anesthesia, so you are not worried about the neurology of the patient, and at the same time everything is under vision. So nothing is like you are putting the instrument, you are opening the jaw and you don't know what you are catching. So that way this lateral decompression, it is very safe and very effective because then immediately once you remove the phlegm you can see the part of the dura, and you can just finish your job. So like sir, this is also like this patient I'm planning for the next week. I just see it a few hours back, and so here the patient was having the big up migrated herniation at L23. So
We are not able to see anything.
no,
Again, you need to share your screen.
oh sorry, just a minute.
Start
Okay.
the screen share again.
Okay. Now it's okay.
Yeah.
Okay. So this is just this patient I just did now. So you can see they have now. So Bhupesh, you can see it now, right?
Yeah.
So now this patient is having the very excruciating pain, and you can see there is the big herniation. So it's the third last well-formed disc, and it's upward migrated herniation, and you can see. So like here, this is an extruded portion of the disc, and the best part is this is more medial to the pedicle. So like what we are thinking is, because this is has come from below to up, but usually for this particular patient, our approach is from the up to down. So like from the above disc, we may go in, down, and we do the oblique pediculectomy, and then we can proceed, because otherwise just inside the canal medial to, and especially when this root is this fragment is quite big, and it is compressing directly the traversing root. So this is going to be a difficult case. So here, the going oblique, and this kind of approach of going the oblique to inside the canal, this is going to work. So like I'll keep our group posted about this case if the it all patient agrees, and then we can go ahead. So I think I'm done.
One important comment on this patient, we can go even transpedicular also here. This patient, because the traversing route is almost medial to the disc. So here,
Yeah.
when you just drill the pedicle, you can directly remove, you are directly land on the fragment. You can also remove that via pedicular also, if you don't want to get the disease.
Yeah, Bhupesh, we will do it together. Don't worry.
Okay. And
We'll
one important comment regarding that lateral recess stenosis, the method of removing the ligamentum flavum. Here we have lots of instruments to remove the ligamentum flavum, especially the Dr. Gore said that side curate, which we have side and front curate both. The curates are very important instruments for to tackle the ligamentum flavum, because the facet, you just scrape the flavum against the facet. So it is very easy to remove the flavum from the lateral recess with the curate. If the flavum is in the lower lateral recess, then you can remove with the down curate, down angle curate. If it is upper part, then you can remove with the upper angle curate. And if the dam on the lateral recess just above the facet, just medial to the facet, then you can remove with the front acting curate. And the second thing, there is one of important instruments is there in probably there's a flavum cutter. Yeah, it is very important. Yeah, we have to make 2 or 3 small nicks in the ligamentum flavum, and then we can remove with the up biting forceps. So it is not that difficult to remove the ligamentum flavum if you have proper instruments with you.
Yeah, so like we can make a small nick, and then we can pass the hook. So like my technique, I just cut it, and then I pass the hook. So hook will separate the flavum, and then you can easily take those pieces of the flavum out.
Yeah. And in this thing, what we call it, the remove the superior articular process. If you remove the part of the superior articular process and part of the pedicle, the flavum is which is dangling. So it is very easy to remove with a Carrison punch also. If you are very good in your cannula, very floated cannula in the foramen, then Carrison punch is also very helpful instruments to remove the flavum. And there are various methods to remove the calcified disc also. Same, we can use the up-biting annular cutter. And recently there is one flexible annular cutter is also there. So if there calcification is there in the disc and PLL is calcified, if we are not able to get the free movement of traversing nerve root, then we can use this flexible cutter also, or up-biting cutter also, to decompress the traversing nerve root.
Okay, and like one thing which I want to discuss between all of us, that we are more happy by using this the manual bone drill, or we are using the rasp manually rather than using the burr or a flexible burr. But we find it's more effectively, because at the same time it removes the soft tissue inside, and we get the better bony decompression. And here the bone is not very hard. So like what is your experience, Bhupesh? Are you happy more with the high speed burr, or you like more of the manual things?
Yeah, but high-speed burr is useful, especially in the disc herniation. If it's different location, herniation is high down migrated and up migrated, or we more dorsal herniation, the high-speed burr is safe. But when there is a especially ligament of lateral recess stenosis or where the hypertrophy of flavum or osteophyte, I find the manual burr it's a very safe because here we can control the movement. Sometimes with the high-speed burr, the movement is not in our hand. Sometimes we may have unnecessary jerky movement and patient may scream with the nerve root pain or we may injure the nerve root sometimes. So I feel high speed work, the manual reamer is very good to in order to enlarge the foraminal window and to remove the osteophyte and burr also. But yeah, for osteophyte in the lateral recess, if the osteophyte is there in upper or lower end plate osteophyte, then we may need to use the burr, especially with burr is low speed burr. 8,000 RPM or 7,000, 6,000 RPM is safe probably.
And again, one most important the fact about this manual bone drill or manual rasp, that they are designed in a way that they are not traumatic to the nerve. So like if you rotate it the clockwise, only it will cut. If you rotate it anti-clockwise, there is no cutting mechanism. So that way the removing the soft and there are small edges inside the serration, in which when you rotate it, it will take out all the soft tissue and the soft bone tissue inside. So that way it becomes more safe, and it's like more effective, especially in the stenosis cases.
I think let us now start the discussion and question answers so that we will be able to answer the queries, etc. In the meantime, on the chat window, I have sent a paper on lateral recess or lower zone stenosis by our great grandfather endoscopist, Dr. Parvez Kambin. You can have an access to that paper, which is just there. I have sent it. And we should now be open to questions. All those who would like to ask questions or make a comment or share an experience, please unmute yourself and talk, or you can put it in the chat window. I can read. Now, there was one question for you, Bhupesh, which I already answered, but again, I'll repeat. What is the limit medially for the oblique pediculectomy?
Yeah. Most of the time, to remove the or to do the oblique pediculotomy, it should be done with the burr, not with the manual reamer. So when you are doing with the burr, under CM guidance, you have to reach with the medial cortex. When you reach the medial border, and then you just have a feeling that it just a thin shell of the bone is there, then that bone you need not to use the burr at that time. You just remove with some curates, articulating curates or annular cutter. Because once you reach the medial border, traversing route may be there or may not be there. It's more medial to the flavum, but sometimes it is, if it is laterally, then you may injure. So you reach to the medial cortex, you have some small give way feeling. Reach there and then remove everything with the up-biting forceps or Garrison punch and or whatever instruments you have with you. Small forceps you can use. And sometimes if small shell of bone and if you make a rent on that medial cortex, then also you can use the Garrison punch, because Garrison punch, it's very safe. It's a guard up front. So we can use the Garrison punch and we can just cut make a window, we can enlarge that window. And we remove the flavum with the lateral recess. And for that removal of that flavum, you need to use that flavum cutter. You make small 2-4 nicks, and then you go use the up-biting forceps and you can grab it easily, or you can use with the Garrison also.
Yeah, there is a question for you, Shiraz. The question is, can you use annular cutter for cutting the flavum?
Sir, usually because the annulus what we see is more into the roof. Sorry, the flavum is more in the roof, and the scope what we are using. So you see what is there is at the angle of around 25 to 30 degree. So actually with the straight annulus cutter, it's difficult to go and hold the flavum. So like and here it's not even very easy, because now you cannot depress the or you cannot use the facet as a lever and then you can go and you can. So sometimes it's possible, but otherwise most of the time because of the angle, because the what is seen on the screen is at 30-degree or 25-degree angle, and with the straight annulus cutter, it's a bit difficult. So even if you have 15-degree or a little more angle cutter, it's more easy. But otherwise, you can just simply try to depress and do it. But usually, it's difficult with the straight annulus cutter.
Okay. Now, please ask your questions, or there is a question for you, Bhupesh, and if possible, show the video again. Please repeat the step of oblique pediculectomy, like step 1, step 2, etc., so that we understand what you exactly do in oblique pediculectomy, right from your access, entry, identification, and which instrument, and where do you start, where do you stop. And for example, a dumb question like, suppose you are drilling the bone, what happens to the bone dust? Is it under irrigation? Is there any anesthesia? So please explain the steps.
Yeah, now I'm starting from beginning. First, we are doing inside out. We are not talking about any outside in technique. Here, first we need to mark our needle in AP and lateral, medial pedicular line, and posterior annulus. We have to do the we have to reach in the needle with the intradiscal access. Then we put our dilator, guide wire, dilator, cannula. Once we are reached with the cannula, we put our scope and we just see whatever the structure in front of us. Mainly, we can see the disc, intradiscal tissue, and we just try to debulk that tissue. Gradually, when you finish that work, you make some space over there. Then you gradually remove your cannula, gradually come out and stay in the foramen. And you gradually rotate the cannula down caudally. And you are around 1 o'clock position. When you are 1 o'clock position down migration, caudal rotation, you can appreciate very well the junction between superior articular process and lower pedicle. So when you reach that junction, then you with radio frequency, you just clear that area because there is a lots of soft tissue over there and some bleeder and oozers also there. So you have to be very clear that you are in that area. When you see that junction, you start burring from superior to angle to the down caudally, the cranial to caudal direction. Start from the SAP, you just burr that area, then gradually rotate your endoscope and try to burr the junction of the SAP and pedicle and gradually come down to the pedicle. And till you reach the junction of the disc and the vertebral body and the pedicle, you have to make a circular window. Gradually, when you make a circular window, gradually you can go forward with, I think diamond burr is very good here because with the cutting edge burr, there is lots of oozing from the bone. So sometimes our vision is obscure. So here we use the diamond burr. With the diamond burr, you just remove the part of the pedicle in oblique fashions around 30 to 40 degree or 30 to 45 degree angle. You go till under and you see, we confirm with the CM frequently in the AP view. Lateral view, there is no role of the lateral view here. Most of we can see the AP view. We can see the nicely your position of your burr from lateral to medial. When you reach the medial window in the CM, you can see, you just stop it and just with the what we call is dural dissector or palpation hook, we just put that hook whether the thin shell of the medial pedicle is there or not. If the thin shell of the medial pedicle, you just enter the medial side of the canal, medial side of the pedicle, what we call, with that burr. And when you make some window, then you use the carison or curate. In here, there is no much space for the curate. Hello. So use the Carrison punch is very good. With Carrison punch, you again enlarge the window a little bit, and then you can see the phlegm, or if there is a disc herniation, so you can see the herniated part of the disc also in the lower pedicle area, lower recess zone, lateral recess zone. So with that ligamentum phlegm, if you can able to remove with the Carrison punch, then you can remove with the Carrison punch. Otherwise, with the phlegm cutter, you make small nick to fornic over the ligamentum phlegm and remove with the upbiting disc forces. Here, the role of straight instrument is not great because the phlegm is in upper part. So many times your straight instrument just go and come out. You may not grab anything. So all the instrument which has almost 30 to 45-degree angle are very useful. You can also use the hook. Sometimes you can use hook used against the pedicle or facet. You can remove the phlegm on the lateral recess. And obviously, disc with for a disc you can remove any straight straight angle forceps or whatever you are comfortable with. Here, the role of the annular cutter is not great because annular cutter it's cutting edge. So many times, if we are not able to see the structure medial to the structure what we are removing, suppose it's the ligamentum flavum, we are not able to see anything medial to the flavum. Then sometime use the annular cutter may injure the nerve root. Yes, annular cutter has definite role in the removing the osteophyte. If his osteophyte is too hard and it's up in the upper, like in the posterolateral angle of the inferior vertebral, superior vertebral body. So at that time you can use the annular cutter because here we are removing against the bone or against the disc. Then it's safe. But in the epidural space, it is not safe to use annular cutter. This is what I believe.
Yeah, I have one small comment there. You have to also mention that the consistency of the ligamentum flavum in a young patient is much more elastic and it is much more like a sheet of material. Whereas as the age progresses, the ligamentum flavum also becomes very thin and broken down, sort of. So even with the hook, you can make short pieces of the ligamentum flavum and can get them out very easily. In addition, if you use a curette, it can also be removed. In addition, of course, the burr is there. Now, there's a question for you, Bhupesh, and then there's a question for Shiraz. The question is, how much ligamentum flavum do you remove? I mean, can you give an estimate of the volume which you remove?
So,
Amount.
it is very difficult to gauge the exact volume of ligamentum flavum, but what I usually follow, we remove the superior articular process, we do the oblique pediculotomy, and we reach to the dorsal to the traversing nerve root, or and then we remove whatever the structure in front of us, whatever amount of ligamentum flavum is there, we remove with the carison or biting forceps or whatever curette we can see. And then if the traversing root is freely float, and we can see the complete movement of traversing root from start from the 11 o'clock to 3 o'clock or 2 o'clock position, then that much of tissue we need to remove. If we are not getting good movement of traversing nerve root, then your decompression part is probably incomplete.
I would say that the answer should be I remove enough. And the next point of the answer should be you are working on the shoulder of the traversing nerve, where it is slowly changing from traversing to exiting at the lower level. So you see that curve, you see the nerve curving around and going down. So your job is done. So that may be a test of adequacy. Now the question is for Shiraz. Shiraz, question for you. You always do decompression on the symptomatic side or do the other side as a prophylactic? And how do you protect the nerve? And as most of the time, we do see the stenosis on non-symptomatic side also. So two questions. Do you do always the symptomatic side alone or both? And how do you protect the nerve root? You have to unmute yourself, Shiraz.
Okay, sir. Now, sir, sir, basically, when we see the pathophysiology of the stenosis, so like this patient, they are always symptomatic when they are either standing or walking. So it means there is no direct compression, there is no mechanical compression, there is something dynamic is there, and that dynamic compression is coming. So this vascular this vascular changes, this vascular congestion can lead to the further compromise in the canal, and that is the reason for the patient's symptoms. So, like here is a very critical that when the patient is having the symptom on the one side, it means all the adjustment or all the natural protection is there inside the spinal canal. It is already been used, and now even there is a small vascular changes, vascular congestion, especially the venous congestion. It will lead to the further stenosis, and that's why the patient becomes symptomatic. So when you see this patient and when you do the decompression on the symptomatic side, usually the patient will get benefit also because it's the same spinal canal. The spinal canal is only one. The roots are on the two sides. So we always do the decompression on the symptomatic side, and since we are also relieving the vascular congestion by doing the decompression, so it will always work and it will always help on the other side also, which is looks stenotic on the radiological investigation, but the patient is still not symptomatic. So they do very well even after doing the unilateral work. And the second thing also, like we work on the roof as well as on the floor. So when you find the annulus is also the calcified, and when you remove the annulus, that will always help to this patient also. So that's why working on the symptomatic side, it will also work on the other side also, because it's the same vascular congestion which was responsible, and if you reduce the sum of it, it will always work for those patients. And the second question was how do we
Yes.
protect the nerve? So like, yeah, so here, sir, when we I don't understand the question where this is about only for the lower zone surgery, or the question is about any disc or upper zone or mid zone or lower zone surgery. So basically, the biggest protection is your awake patient, because whenever we touch the patient or whenever there is a mechanical or chemical irritation, the patient will immediately say that, "Oh, doctor, I'm having pain going down to the leg." So the first important work here, that don't anesthetize the nerve while you are working. Otherwise, you will miss that protection, and you will miss the main advantage of doing this surgery under local anesthesia. Secondly is that like for the routine disc surgery, that's why we always promote to do the inside out technique, because once you are inside the disc, you are inside, and there is no nerve inside the disc. And then once you work in the once you come out, you are working in the foramen, and you know everything because you see everything on the TV screen. So since this is done under local anesthesia, this is everything is done under visualization. So the nerve injury will happen only if you either anesthetize or if you do the blind job. So if we keep these two things in the mind, and third thing is, like, whenever you have a doubt about the structure that you don't know, just put the hook and probe it, and you ask the patient. So at least the patient will report you, and you will be very sure that, okay, this structure is the nerve, we are not supposed to touch this. So just if we stick to the basic principle, then definitely there is no chance of complication, at least especially the nerve injury, and that usually happen with the gross mistake, and especially for those who either do it general anesthesia, or they will put the local anesthesia inside the foramen, and then they do
Raj, your sound is not good, not proper. It's little.
yeah, actually, sir, I'm traveling. Okay, I can just stop my car. Car is on.
Yeah, okay, no problem. That's not a issue.
Yeah. So,
Yeah,
like,
now it is good.
yeah. So basically, we have to stick to the basic, and we should not try to do anything extra. And if we just follow the philosophy, the chance of complication, especially the nerve root injury, will not be there.
Yeah, I'm just trying to share my screen and show one paper from one of my friends from Taiwan. As you can see here, are you able to see the paper well? Share the screen. Are you able to see the screen
Yes, yes.
properly?
Yeah, we can.
Yeah.
So here we are showing you L5S1, which is done. On the left is a pre-op picture. On the right, in the upper part, is a post-op picture. And you can see very well that what they have done is they have worked on this portion to do the foraminoplasty. Now, this foraminoplasty is mainly to gain an entry inside the area. And this is an intra-op endoscopic view where on the left they are showing you that the S1 root is seen very well going down in the lateral recess, and on the right they have shown that they have removed the superior articular process very properly. Now this is what somebody was asking, what exactly you do. Now here again you can see in this picture, of course here the surgeon is doing this on a cadaver, So he can be very aggressive. As you can see on the left, what they have done is they have identified that the SAP is causing an issue, and on the right, they have removed the SAP almost in total. So you can see that this is the picture which is after the removal. And so what this would make you understand is that it is very possible to work in the lower part of the foramen under local anesthesia, remove all this bone. Now there is a question for you, Shiraz. How much and how deep and what anesthetic do you inject? Yeah, unmute yourself before you answer. Shiraz, question for you. How much, how deep, and what do you inject as an anesthetic? Bhupesh, you can answer in case Shiraz is unable to answer. Unmute and answer.
Sir, Shiraz sir is unmuted only, but we are not able to hear sir's voice. As you can see, sir is unmuted only, but we are not able to hear voice.
Bhupesh, unmute yourself and answer.
Yes, sir.
Okay. How
So,
much do you inject? How deep do you inject? And what do you inject as an anesthetic?
yeah, for the skin infiltration, we use the 2% lidocaine or lignocaine. And what I do when we reach the foramen with the needle, our transforamen needle, when we reach in the foramen, I dilute the lignocaine to 1%. Here, what you do, I use the 5% normal lignocaine and 5% distilled water or normal saline to make it to 1%. And then I inject around 7 to 8 cc in the foramen. So that is enough for relief of the pain. And then we usually I don't do inject inside the disc, and after that we don't need to inject further. Usually total 10 to 11 cc total lignocaine we need, 3 to 4 cc lignocaine in the skin. We don't need to inject anything in the muscles or lumbar fascia or any other plane, except we need to inject around 7 to 8 cc lignocaine, diluted lignocaine up to 1% into the foramen, so that entire things, especially traversing nerve root and pain producing structure in the foramen, which get anesthetized.
Okay, very good. If there are any questions, again, please kindly unmute yourself and ask, or you can put it in the chat window. And I would also, in the meantime, try and request some comments.
So participants can unmute and they can interact, sir.
Yeah, please unmute yourself and you can make your comment, and you can add to the points under discussion. So we are also benefited from your perspective. Yeah, Dr. Neeraj, what is it?
Good afternoon, sir. Just want to share one small thought. Maybe we want to lead from you. When there's a kind of a global stenosis, like there is a disc fragment, large disc fragment, and some facet hypertrophy and some ligament hypertrophy as well. In those situations, is it wiser to do a little of bone work first at the foraminal area, SAP area, get into the disc, do the discal work, decompress from the disc, so that there is a neural structures has a decompression, because when you come out, then you can work more in the lateral recess and the lower zone, so your neural structures have a place to go, actually go away from your instrument, and you can do a little kind of a more bold work on those ligament flavum and the bone, pediculectomy and other things, because you already given a space to the nerves to go. Otherwise, if it is really compression from the disc side and you're doing anything at this side, because then the neural structures are falling onto you. So it's advisable to get into the disc, do the work first, and then come back and do the rest of the work. What's your thought, sir?
Actually, you see, there are 2 points here. Point number 1 is, if you are doing a disc related surgery, then it is much more logical to go inside the disc first and finish up the job and come out, because the epidural venous oozing may cause issues about visualization. But here we are talking about lower zone or lower part of the foramen, which is obviously smaller than the upper part. Of course, it is safer because the nerve is not there. But because it is smaller, we need to improve the size of the foramen first. So many times we would advise doing a cutting of the bone first, then go for the disc or for the ligamentum flavum work. But here you must remember that in bony work as well as the epidural work, it is many times very, very bloody. So you must have adequate measures to control that. And oh, am I audible or not?
Yeah, you're clear, sir. My condition was is when there's a significant disc fragment also along, in those situations, it's good to take the disc off and then you do your rest of the bolt work.
Absolutely. Yeah,
That is
correct.
my
Yeah.
condition.
Okay, correct. What you said is right. I totally agree with you. Only thing is sometimes if the disc herniation is down migrated, medial to the pedicle, hardened, chronic, with ligamentum flavum, elderly patient, medical comorbidities, severe claudication, then I think we are slowly pushing it more towards the bony work and more towards extra discal work. Of course, you can always start inside the disc, but it would probably out of 100, it will be 20% inside the disc. Yeah, Bhupesh, what is it?
Usually there's combined mid zone and lower zone stenosis. Most of the time, disc is also causing some stenosis, then lateral recess, ligamentum flavum, facet, and all four structure responsible for stenosis. So if
Yeah.
there's combined mid zone and lower zone stenosis, then it is usually advisable to start from mid zone, because when you remove the disc, you are much more oriented what you are removing the structure. Then gradually you come out, then you reorient yourself to the lower pedicle and superior articular facet area. So here it is advisable to start from mid zone and gradually go to the lower zone.
Rest.
I agree. Absolutely. What you said is absolutely perfect. There's one more point here. The point is the same which we have been highlighting when we started talking about transforaminal access to the stenosis. That when you do the surgery from behind, when you do the interlaminar surgery, many times you ignore the disc changes. Many times you ignore the changes at the end plate in the form of osteophytosis, etc. And what you are trying to do is you only concentrate on the posterior wall changes. And you just try to tom that you are doing a wide interlaminar clearance and laminotomy, and you're trying to go in the lateral races and remove the medial facet. All that is irrelevant. I think there is a over emphasis on posterior structures, and I'm sure that the posterior axis many times misses the point which we are able to cover, because we can go in the front as well as the back of the dural sac in addition to changes in the foramen. So this is a very important point which I'm making. I'll just repeat. With the transforaminal axis, you can go in front of the dural sac, behind the dural sac, and on the side of the dural sac in the foramen, in the upper zone, middle zone, and lower zone. Posterior midline surgery can only tackle the changes which are there in the posterior wall primarily, and in some cases when you go under the facet in the lateral races. Yeah, Dr. Chabra, you have raised your hand. What is it? Please go ahead. Unmute yourself and ask your question. Yeah, Dr. Chabra, you wanted to ask a question. Go ahead.
Out like
Yeah, go ahead. We're not able to hear you properly. Please go ahead. Dr. Chabra, please ask your question or type it in the chat window if you are unable to connect with your audio. Sometimes there is an issue with the audio. Recently, we have seen with Zoom, I think this issue is coming up a little bit. Now, I wanted few of our colleagues to comment on this, what we have just talked about. Yeah, Dr. Anand is asking a question. Measurement of the pedicle preoperatively, will it help intraoperatively? Not really, because our work is not relevant to the pedicle. You can say measurement of the foraminal size, measurement of the foraminal diameters, antero-posterior, etc., would be more useful. Yeah, Dr. Chabra, now I think you're talking, but we are unable to hear you. I answered Dr. Anand's question. Will the measurement of pedicle preoperatively make any difference or help in intraop? Not really. Pedicle width or height is not relevant to our work. What we are saying is, if the problem is on the medial aspect of the pedicle in the lower zone, if we are considering a medial oblique pediculectomy, then you should not exceed medially beyond the medial pedicle line, because you're already going to land on the shoulder of the traversing nerve where it changes towards exiting nerve. Yeah, Dr. Chabra, we are waiting to hear your voice.
Yeah. Hello, sir. Am I audible, sir?
Yes.
Yeah, sir. What Dr. Jain sir told regarding the inside out technique, and he was more concerned whether we should go always from inside out or we should go outside to in. Sir, I just want to ask you, like, for a beginner, we should always follow inside out technique.
For a beginner, you must follow inside out technique. Why? I will tell you a couple of reasons. Number one, it is very safe. Number two, once you are inside the disc, you are in a avascular, neural zone. So there is no pain and there is no bleeding. Number three, you can orient yourself very properly to all the structures around you because you know exactly where you are and you cannot make a mistake. Suppose you are too much inside the disc, you can always come out, orient to the posterior annulus, and again decide where to go. And you can also be very effective, especially if there is a disc bulge, disc herniation, annular tear, trap fragments, which is the commonest presentation of degenerative lumbar spine. The important thing is outside in. Please understand one very simple thing. The outside in is essentially a more mature thinking. It is mainly a blind fluoroscopy guided undercutting of the superior articular process. If you are unsure of the veins, if you are unsure of the furcal nerves, then you may damage them when you are doing this blind cutting of the facet. As Dr. Shiraz showed in his videos, when you use a trephine or you use those burrs on the undersurface of the facet. The other problem is if you're not oriented very well and if you're dealing with chronic pathology, then what you are doing is likely to give more bleeding in that area once you put your scope. One more thing I'll again emphasize is inside out is endoscopic visualized surgery. Outside in is a blind fluoroscopy guided landing inside the canal directly. Then you put the scope. In fact, if you look at people's outside in demonstrations, they do not actually show how they go there because it's all fluoroscopy. So it is very likely to be problematic if there is an issue with the vein and with the nerve. I would suggest as a beginner, stay with inside out. Okay, there's a question for you, Bhupesh, and for Shiraz, if he is there. What is the difference in the lower zone surgery for L4-5 and for L5-S1? I would make one comment before you answer. For L4-5, lower zone surgery is for L5 root, which is going out of the disc at that L4-5 level and going to be a exiting root at L5-S1. In case of S1 root stenosis, we will be doing a lower zone surgery for L5-S1. The second, the difference is for 4-5 lower zone, it is for L5. L5-S1 lower zone is for S1. Second difference, which is the commonest difference, is at 5-1, almost always you will be directed to the lower zone because you're coming above the crest. Whereas 4-5, you're not directed to the lower zone. You may be entering the disc, etc., and then you may have to change your direction or your trajectory. The third thing is because you're directed towards the lower zone, L5S1 lower zone surgery is much more easy, is much more, let's say, better oriented surgery because you're just there. But of course, for those who are scared of the high iliac crest and they feel that they won't be able to enter inside properly, you have to be more, you have to study the images more preoperatively. The third thing is there is a factor, what is called as facet tropism. I I know that most of you have heard or understood that, but I'll just clarify in 1 minute. Most of the facets are like this, that is at 45 degrees. So they come towards the center of the disc. Now they may be vertical or they may be more horizontal. If they are more vertical, the canal is wider, but in the foramen, you feel as if the SAP is very, very adamant and is coming in your way of entering the disc. That is where you need to use the burr. And at L5S1, if the crest is high and the facet is more in the coronal plane, then it becomes a difficult surgery. Whereas 4-5, almost always, you should be able to enter properly. Bhupesh, what are your comments?
In L4-5, when we do the lower zone surgery for L4-5, the use of the high-speed burr, articulating burr is very good, very much easy here. So here we can use the burr and the playing of the instrument. What we can is the freedom of the movement in the foramen is very good. But as L5S1, what usually I follow for L5S1, because most of the time the L5S1 facet is hypertrophy. As such, L5S1 facet is very large. So here we need to enlarge we need to remove the bone little much more than L4-5. So what I do for L5S1, I usually start with the hand rimmer. What that Max Moore has made, that hand rimmer. We usually start with the 4.5 mm rimmer and gradually we enlarge the window till 11 mm. So in most of the time, this rimmer can finish our job most of the time. But L4-5, many times this rimmer are not that helpful to remove the pedicle. But in L5S1, because our trajectory is like above downward, so it is very easy to remove the part of the superior articular process, the junction between superior articular process and lower pedicle and pedicle part. So it's very easy with the articulating burr. So for me, L5S1 canal stenosis is very easy rather than 4-5.
Yeah.
What's your comment?
I would have one small comment on that, easy or difficult. I would say that if you're dealing with a female patient who is a height less than 5 feet, then you need to be extremely cautious because the foraminal size is going to be small. The lower zone size will be very, very small and you cannot play there. The second point is if you're operating in the lower zone in such a patient, you should not give too much of local just to make the patient comfortable because you may land up with some neurodeficit very easily, especially in a short 5 feet tall female patient. Please remember that the morphometry in a female Indian who is less than 5 feet in height is difficult to deal with larger scopes, larger cannulae, and all this drilling, cutting, and burying the bone. You have to be very cautious. Now, I would like to invite a few more comments. Dr. Girish, would you like to have a comment? And I would also like Dr. Pal to have a comment because Dr. Pal, you were mentioning the other day on our Facebook page about foraminoplasty and foraminotomy. I would suggest, I feel that by this time the difference must have been clear to you. But if you still have a comment or a question, you are welcome to offer your view. Dr. Pal. Okay, I think he is probably, yeah, okay, fine. And what we feel, Dr. Pal, is that what we are doing in case of stenosis is improving our access so that we are able to be more effective. Now, there is a question, what is the incidence of root injury in transforaminal surgery? Bhupesh, any comments? After you, I will answer. What is the incidence of root injury in transfemoral surgery?
Yeah, the incidence of root injury is more when you do the direct lateral approach. Here, we are exiting root is at the risk of damaging it. So, for basically for stenosis surgery, the injury chances of the root injury is very low. Why I'm saying, because we are not going too far, too lateral. From we are not taking entry too lateral, because here the disc is not an issue. Here more we want to clear the lateral recess. So I have not encountered any injury. Yes, sometimes with the using too much radio frequency machine, because in the lateral recess lots of bleeding is there. So sometimes when you use the too much radio frequency machine, then at that time some numbness is there, but no motor weakness probably.
Okay, I have a comment on that. Number one, if you are going too much anterior in the foramen, that is ventral, then the chance of injuring motor roots is very high, especially in the upper lumbar area. If you are operating L3-4, L2-3, L1-2, then that is a problem. The second point is this motor injury will not be evident to you because the patient doesn't have any pain, but the patient will wake up with a weakness of the quadriceps. So that is number one. Number two, the chance of injuring the exiting nerve theoretically exists. But please remember that exiting nerve is always on the body of the vertebra, it is never on the disc. So as long as you're entering the disc properly, that is between the end plates, then you should not have any issue. The chance of injuring the traversing nerve is theoretically there if you use an annular cutter inadvertently without seeing the tip of the instrument, and you can damage it. The chance of injuring the nerves by use of very, very high RF next to the nerve is theoretically there. It doesn't happen. And overall comment is there is no chance of injuring the nerve, mainly because the patient is awake and aware. So the moment you're close to the nerve, the patient is going to tell you, yell at you, or point it out to you that it's very painful. I can say I'm very proud to say that in last 20 years of my surgery, I have never ever injured a single root. Never, not even one single root injury. There have been cases where we have had hyperesthesia, dysesthesia, because of a very tight canal or a tight foramen where we have worked around the root and given rise to excessive irritation of the dorsal root ganglion, which nowadays is much more easy to control than when we started 20 years back by use of gabapentin, pregabalin, local injection of steroid, local injection of PRP, etc. So that's my answer. Now, Dr. Pal is asking a question. Can you talk about
One
docking the
more is
channel?
that the duration of surgery is also very important. So,
Yeah, yeah.
as because we are putting our cannula between the in the axilla, between traversing and exiting the root. Many times the maneuver of our cannula, when we move more dorsally, when we start levering against the facet, at that time exiting more is at the risk. So when we are doing anything, when we levering the cannula, it should be momentary. We should not keep cannula more and more levering, and we do the all the work. We remove the during the remove the phlegm, all this thing. So if it's possible, you do the bony work more from beginning only, and don't lever the cannula too much, because the stenosis surgery is little longer than disc surgery. So here you will take little more time. When you are putting a cannula longer duration in the axilla, there's chance of numbness and irritation to the dorsal root ganglion is more. So as far as possible, don't lever cannula too much. You when you want to remove the dorsal structure, especially ligamentum flavum and part of the facet bone.
Okay, there was a question by Dr. Pal. Can you talk about docking the channel? Now, I'll make a short comment. After that, Bhupesh, you can make a comment. Shiraz, you can also make a comment. You see, basically, we must remember that in case of transforaminal endoscopy for the disc, the cannula should be anchored in the annulus as far as possible. I mean, earliest possible in the surgery. There are surgeons who, after doing a couple of hundreds of cases, can keep the cannula floating and then they can operate, but it is not advisable for a beginner. You must anchor the cannula in the annulus, number one. Number two, what you have to remember is if you are coming too flat, that is, you are coming, say, about 14 centimeters from the midline, it is very dangerous because you may not be going below the intertransverse ligament. In which case, as I mentioned some time back, injury to the ventral structure there, that is the lumbar plexus, is a strong possibility. So never go beyond 11.5 or 12.5 centimeters from the midline in an average height person. Number three, in case of L5S1, the docking of the cannula is not needed right up to the annulus sometimes. Why? Because the extra foraminal structures at L5S1, mainly the transverse process, the iliolumbar ligament, the iliac crest, the ala, and the facet at 5.1, that is the S1 facet, they have such a bony configuration that they themselves hold the cannula in a very good position. The next point is when you're docking the cannula, when you're putting the cannula in the disc, you must remember that it is a very sharp instrument as compared to the dilator. So it never ever is used individually. A cannula is always used over the dilator, never used singly. The last thing is when you put the cannula inside, we have been talking about this. You look at your own thumb and the index finger. For the left side, you look at your own left thumb and the left index finger and the first web space, and you are going in that first web space. On the left, you are going, uh, see your left hand, on the right, see your right hand. And when you're doing this, then you turn the cannula in such a way that the opening of the cannula or the bevel of the cannula is towards the head, so that the tang, that is the tip of the cannula, never injures the exiting nerve. Bhupesh, any further comments?
We always need to use the dilator with over the cannula. So cannula alone is not safe at all. And many times, I think as our basic technique, we should always keep the cutting and the bevel edge of the cannula towards the axilla, especially in the L5S1, because many times L5S1 of our trajectory is like that. We have to go from above downward. So many times we have encountered that. Some patient have excruciating pain on L5 nerve root. That is because of pressure on the L5 nerve root because the area is very narrow. So, sir, in most of the time, I prefer to use hand reamer for the L5S1 because with the L5 using the L5 hand reamer, we start from 4.5 mm and gradually we enlarge the window foraminal, so we can have a space more dorsally and the chance of pinching or exiting nerve root is very less. So nowadays I started using almost in alpha S on all the patient with having a manual reamer, and that give it more freedom to operate in that area especially.
Yeah, that is fine.
And
The only
then
thing you have to remember is that you should never be too ventral in the alpha S1 foramen because there are important structures ventrally. One of the most important structures at L5S1 ventrally is what? Tell me, what is it? It is the
uh,
ascending lumbar vein. Not
mm,
not really very close to the foramen, but that is one of those. And please remember that ascending lumbar vein is a ventral structure to our foramen. We have to be very cautious. Okay, Shiraz, your comments on the docking of the cannula.
Okay, sir. Sir, I just want to give some pictorial information what you already spoke about, and in addition to that, that whenever we find either there is the collapse disc, then you can use a small size dilator, maybe the 4 millimeter or 5 millimeter dilator. So then once you go inside the disc, and then you can take it out and you can put the local, and then you can go with the bigger size dilator. I just want to share my screen, and I just want to repeat those words which you already said. So just Jayesh, can you allow me to share my screen? Hello.
Yeah, what is
Yes,
it?
sir. Yes, sir. Yeah.
Yeah, I just want to share my screen.
Yes, sir. You can share
Yeah,
your
okay,
screen, sir.
share it.
Please.
Share it. Yeah.
Yes. sir, I'm using the same slides by
Okay, sure.
you. So like this is this slide is very very important. This is one of the very important step here that sometimes, because once you are not used to, then you forget to hold the scope, or your assistant forget to hold the scope, and when your cannula is floating, because you are just below the nerve root, and it may happen that
You have to show that slide. I think you have come to our view. You have to go. You have to slide it up. I mean, you showed
okay,
it correctly first.
can you
Yeah.
see?
No, we are not able to
Yeah,
see.
so can you see?
Yeah, we
You're
see
not
the
able to
scope
see.
in extreme lateral transforaminal axis, but a slide below that is more important.
Yes.
Yeah, correct.
Now
Go
with
down.
this
Yeah,
yeah
perfect.
now yeah. So with this the extreme lateral angle. So here also the important is to be careful about the dorsal root, and especially the motor root. So here I just want to see this slide, and especially in the upper lumbar area. So you can see the lumbosacral plexus is how close to the posterior part of the vertebral body. So here, if you are very flat and if you don't come at
You are not
the
audible,
angle, and
Shiraz,
if
but
you
we
come
can
with
see
it
the
may
slide. Yes. Now, in the
yeah.
meantime, just have a
So
small comment. Yeah, okay, go ahead, go ahead. I'll talk later. But leave the slide on. Shiraz, your voice is not there. Uh,
I'm on the road, and
yeah, I
now
understand. I will make a comment. Don't worry. Just leave the slide
yeah,
as it is. Just slide up, up,
yes.
go up. Yeah. I mean, yeah, show the lower slide.
Yeah, I
Yeah,
understand.
that is fine. This is fine.
I
More
will
than
make a
enough.
comment.
Fine,
Don't
fine.
worry. The slide as it.
Okay.
Yeah. I mean, yeah. Show the lower slide. Yeah,
That is fine.
this is fine. I will make a comment. Fine.
Yeah, that lower slide with the femoral nerve, I wanted you to show. I hope Dr. Pal has seen that slide. That is what the femoral nerve is on the side of the vertebral bodies in the dorsal aspect of the psoas muscle. And we have to be extremely careful as to avoid any damage to that structure by docking very correctly. There's one more point. If you come at around 12.5 centimeters from the midline, you get a good chunk and good thickness of the annulus to go in. If you're coming too flat, you don't get much thickness of the annulus to stay. So what happens is you're likely to be floating. The end of the cannula may be floating, and inadvertently, unless you have a holder to hold the cannula during surgery, you may be irritating the nerve or the dorsal root ganglion unintentionally, accidentally. So you have to be, that was a very important question, Dr. Pal, which you asked. Docking of the cannula, it's very, very important. Okay, now we go ahead to, yeah, good that you saw it. So any more questions or comments? Otherwise, we are going to wind up in next 5 minutes. It's exactly 4:55. So we will be winding up now. Are there any comments, suggestions? Dr. Girish, I had asked you to give us your comments. So in case you are there and able to connect, please give your comments.
Okay, sir. Meanwhile, I just want to share one of my clip where I had a nerve injury. Hello.
Okay, I think Girish is not able to connect. Any other questions, please, before we wind up? Before winding up, let me remind you next webinar on Saturday would be our last webinar in this series on transforaminal endoscopic surgery for lumbar canal stenosis. And we have covered right from imaging, concepts, clinical evaluation, choosing a patient, pre-op planning, upper zone surgery, middle zone surgery, lower zone surgery. So our last one is going to be sum up and some more presentations and sort of coming out with a crystallized vision. And we will be talking next time also about the instruments. I mean, what instruments which we use, and we would probably be having all of us showing their way of use of instruments, mainly the curette, the drill, the shaver, the graspers, the hooks, the bendable curettes, the bendable graspers, bendable annular cutters, etc. So all my colleagues should be ready with their presentations on instruments for lumbar canal stenosis, and then we will cover that topic. So now I formally thank Shiraz and Bhupesh for taking time from their busy schedules and joining us. Now, uh, yeah, Dr. Pal is saying, can the initial presentations be hosted on YouTube? Yes. We are actually trying to collect all of them and send you a link so that you can download or watch or share or whatever. So we'll do it very soon. So after thanking Shiraz and Bhupesh, I am handing over the mic to my colleagues from Alembic. And I thank Dr. Chirag Modi and Jayesh and all my colleagues from the team in Alembic. This has been a wonderful support which you have given. And in our small way, we have been able to sort of spread our message to our colleagues and friends. So over to you, Jayesh.
Yes, yes. Thank you so much, Satish Chandra Bore sir. And as correctly said, thank you so much, Shiraz sir. And thank you so much, Bhupesh sir, for this wonderful presentation on today's mid-zone surgery. And apart from that, also I would also like to thank all the participants who took in the precious time to attend this seminar and making this a very very interactive one. And I have already forwarded the videos to Satish Chandra sir and as well as other delegates. And this also will club and will make sure that we make it available online on YouTube as well. So thank you so much, sir, once again for believing in us and giving us an opportunity to conduct all these 8 seminars on our platform. And in future also, we will conduct and we are ready to conduct many such more initiatives by Mission Spine Foundation, sir. We are always there to, for conducting such platform, conducting such CMEs. Once again, thank you so much, sir. And thank
Yeah,
you to all the delegates and faculty members.
yeah, thank you very much. And let's see
Thank you
you
so much, sir.
again on Saturday.
Yes, let's meet on Saturday, sir. See you. Yes. Thank you, Shiraz, sir. Thank you, Bhupi, sir.
Thank you.